2. Elective joint replacement. The most common joint replacement electively are the hip, knee, and shoulder. The most common indication is osteoarthritis that we discussed previously. Most patients that have joint replacement are over 60 years, but in our places, mostly it can be even less than. And actually, joint replacement, due to its high cost, is not mostly done in our places. The artificial joints are built in to last more than 10 to 15 years. However, they may be affected by losing, wear, and dislocation. Some patients may require further surgery and replacement of the artificial joints at the same points. So, joint replacement is the major surgery. Patient need to have an alternative discussion. And a patient need to have the alternative discussed before deciding to undergo the surgery. So you have to explore all other options if possible. The other options usually includes analgesias, steroid injection, and physiotherapy. Then you see this example of the knee joint replacement, and this is just patella as an example. So what are the indication? Indication number one is osteoarthritis. Osteoarthritis is the most common indication for elective joint replacement. It is not usually performed um, until the symptoms are severe and not manageable with a conservative management or treatment. Joint may also require replacement for fracture or septic arthritis, osteonecrosis, bony tumors, and rheumatoid arthritis. The options here, there are several options for elective joint replacement surgery. So first of all, there is a total joint replacement, or replacing both articular surface of the joints, or it can be hemiotherapy, whereby replacing half of the joint, e.g. the head of the femur in the hip joints. Or we can have partial joint resurfacing, which is called replacing part of the joint surface, e.g. only on the medial joints surface of the knee. So those are the types of the options that are available. Though in mostly these ones are not done that much in our place. So total hip replacement. Total hip replacement, usually a lateral incision over the outer aspect of the hip is used. The hip joint is dislocated, separated to give the access to both articular surfaces. The head of the femur is removed, and the metal or ceramic replacement head of the femur on a metal stem is used to replace it. The stem can either be cemented into the shaft of the femur or carefully pushed into the shaft to make a tight enough fit to hold it the secure place. Or uncemented stem have a rough surface that hold them tightly in the place. The acetabulum sockets of the pelvis is hollowed out and replaced by a metal socket, which is cemented and screwed into the place. A spacer is used between the new head and the socket to complete the new artificial joints. So the other one might be the total knee replacement can be done. Usually a vertical anterior incision is made down to the front of the knee. The patella is rotated out of the way to allow the access of the knee joints. The articular surface, this is the cartilage and some of the bones of the femur and tibia, are removed, and a new metal surface replaces this. They can be either cemented or pushed tightly into a space. A spacer is added between a new articular surface of the femur and the tibia to complete the new artificial joints. You can have also total shoulder replacement. Usually, an anterior incision is made down to the front of shoulder along the deltoid. The shoulder joint is dislocated, separated to give the access to both articular surfaces. The head of the humerus is removed and replaced with a total metal or ceramic ball. This replacement displacement head is attached to the humerus either by a metal stem or screw, stemless. Actually, it is very nice if you can have a video and see what we are trying to speak in picture. The glenoid, which is the socket, is hollowed out and replaced by a metal socket. This completes the artificial shoulder joints. Reversal total shoulder replacement. A reversal total shoulder replacement involves adding a sphere in a place of the glenoids. This is socket and spacer with a cap to replace the head of the humerus. This reversal reverses the normal ball in cap structure of the shoulder joint, but the joint function remain the same. Before surgery, planning for joint replacement surgery will involve X-ray, will involve a CT scan or MRI scan, may be required for more detailed assessment of the joint. It may be done perioperative assessment, consent for the surgery, blood including groups and self, and cross-matching of the blood. Also medication changes if needed, temporarily stopping some anticoagulations like soluble aspirin and other like warfarin if they are used. A venous thromboembolism assessment to make sure that the patient doesn't have bleeding disorder or having thrombus, so that they can have also provided prophylactics. Fasting immediately before surgery, which will be considered, and things like blood sugar and others should be considered in place. The limb will be worked with the patient at work to ensure that the operation is performed on the correct joints. So that's the main thing again, to make sure that operations. So during surgery, joint replacement surgery requires a general anesthetic. Alternatively, a spinal anesthetic may be used for lower limb surgery. Prophylactic antibiotics are given before the procedure to reduce the risk of infection, and tranexamic acid may be used to minimize the blood loss during the procedure. As you know, this is the major surgery and involves a lot of large blood vessels. After surgery, the postoperative management after joint replacement surgery involve analgesias, physiotherapy to guide when and how to mobilize the joints, and VTIE prophylaxis, venous thromboembolism prophylaxis, postoperative X-ray to make sure that everything is aligned accordingly, postoperative full blood count to check the anemia because of bleeding, monitoring of the complication, e.g. deep vein thrombosis or infection, then VTE, venous thromboembolism prophylactic usually involve low molecular weight heparin. The 2018 NICE guideline, as I said earlier, this is the UK guideline. The VTA prophylaxis have specific recommendation or potential regime that can be used for joint replacement surgery. So to read more, you can see either Tanzania guideline, which is having some of these important things. We will have to go one day to see what is happening. Then this involves options of lower molecular weight heparin for 28 days post the elective hips replacement, because we are afraid of risk of embolism. 14 days post elective knee replacements, you can use it. So for 28 days post hip replacement, and for knee 14 days. Other measures that may be used for VTA prophylaxis after joint replacement surgery are you give aspirin or you give DOAC, which is you can give the rivaroxaban. Also, you can give anti-embolism stocking. Risk. So the generic risk for joint replacement surgery are risk of anesthetic, pain, bleeding, infection. Infection of the prosthesis can be a highly problematic. The damage of nearby structure, e.g. nerves and arteries. Stiffness and restricted range of the motion in joint dislocation, losing, and also fracture of the during procedure can happen. Apart from that, you can get the venous thromboembolism, a DVT, and PE. Okay, the prosthetic joint infection is an important component to consider, because infection with a prosthetic joint is a big problem. As you know that there is no blood supply to those prosthetic things. This occur in around 1% of the joint replacement, and extensive measures are taken to prevent it, such as preparative prophylactic antibiotics. It is also more likely to occur in revision surgery rather than during the initial joint replacements. The most common organism is Staphylococcus aureus. As you know, this is common skin organism. Risk factor for prosthetic joint infections are prolonged operative time. The more you operate, the more you expose the patients. Obesity is another risk factor for this one. Diabetic, as you know, the risk for that particular problems. Symptoms include when someone is having the infections, the joint infection, so you will see there will be fever, temperature above 38.0 centigrade. Also pain, the joint you use this will be very painful. Swelling is an important component. Erythemas, the reddenishing of the joints, also increase on the warmness because of the high increase in blood flow due to the infection. Diagnosis involve combination of clinical findings, example those findings that we mentioned, the fever, the pain, the swelling, the erythema, the increased worms. But also you have to do x-ray to see, and also you can do a blood test. Raised inflammatory markers are important markers, including ESR. Culture and sensitivity is important to make sure that what kind of organism grows, and culture and sensitivity as well. Finding during further operation. And also management should involve repeat surgery and prolonged antibiotic over months. Surgery may involve joint irrigation, debridement, and complete replacement. So that was topic number 2. Topic number 3, fractures. Let us discuss a little bit about fractures. Types of fractures, actually. A compound fracture is when a skin is broken and the broken bone is exposed to air. That is called a compound fracture. The broken bone can puncture through the skin, and a stable fracture refers to when the section of the bone remain in alignment at the fracture. So there's nothing like replacement or nothing like a bone coming out. A pathological fracture refers to when bone break due to abnormality within the bone. So you'll see them below. There are several terms used to describe in what way bone breaks. So what way means structural wise, anatomical wise, and we have transverse kind of bone fracture, oblique, spiral, segmental, comminuted fragments, compression fracture affected by the vertebra in the spine, green stick, buccal, torus, and Salter-Harris growth plate fracture. So when you're speaking of green sticks and buccal fracture typically occur in children rather than in adults. And here the bone may fracture but not like complete. You can see more in a pediatric orthopedic. Salter-Harris fracture only occur in children. Adults do not have this growth plate because Salter-Harris fracture actually happen in the growth plate. If here these assume these are plates, it can happen just there. So green stick and buccal fracture typically occur in children rather than adults, and Salter-Harris because these occur in the growth plate, therefore they are mostly in children. Wrist fracture. Before we go that, can you see the diagram here? So we have, this is transverse fracture. This is linear. Transverse is go across kind of in the bone. Linear follows along the longitudinal bones, and oblique is not non-displaced and it's oblique in structure. And we have oblique non-displaced, but you can have oblique while it displaced. You see it is kind of separate. We have spiral. It's like turned out. Someone is trying to, and we have green stick. You see it's kind of bending, not completely fractured. Comminuted fracture is a fracture whereby there is some kind of fragments but not moved, and avulsion is kind of taken to the just point of fracture whereby there is joint. So avulsion fracture, comminuted, green stick, spiral, oblique, and those are the subtypes. So we are speaking of wrist fracture. With this fracture, we have a Colles fracture, referred to the transverse fracture of the distal radius near the wrist, causing the distal portion of the distal portion to displace posteriorly upward, causing the dinner fork deformity. This is usually the result of the fall onto the straightened hand. We'll see them the picture. You can have picture to see it very well. So a scaphoid fracture is often caused by foot. The scaphoid is one of the carpal bones and is located below the base of the thumb. And a key sign of a scaphoid fracture is tenderness in the anatomical sniff box. You remember that one, whereby they used to put tobacco. The groove between the tendons when extended the thumb. It is worth noting that the scaphoid has a retrograde blood supply, with blood vessels supplying the bone from only one direction. Therefore, if they are injured, therefore there's no collateral blood supply. This means that a fracture can cut off the blood supply, resulting in an avascular necrosis and non-communion. Important take is some key bones have a vulnerable blood supply, or as I said, one, where a fracture can lead to the vascular necrosis, impaired healings, and non-union. These are the scaphoid bone, the femoral head, humeral head, and the talus, navicular, and 50 metatarsal in the foot. Ankle fracture. Ankle fracture involves the lateral malleolus, actually most of the time, and distal fibulas and medial malleolus, distal tibia. So Weber classification can be used to describe the fractures of the lateral malleolus, distal fibula. The fracture is described in relation to the distal syndesmosis, fibrous joint between the tibia and fibula. This tibia fibulus syndesmosis is very important for stability and function of the anchor joints. If the fracture disrupted the syndesmosis, surgery is more likely to be required in order to regain the good stability and function of the joint. The Weber classification defined fracture of the lateral malleolus as type A, B, C, and we'll see the A is below the anchor joints, will leave the syndesmosis intact. But B, at the level of anchor joints, the syndesmosis will be intact or partially torn. But C, above the anchor joints, and syndesmosis actually will be disrupted. So it's good also to see the picture for this. Weber classification. I would love you to see the picture if possible. It's always lovely to do that, and you can have a very good picture to see what is happening. And very shortly, I would love you to go here and have a catch up.
Ankle fractures, Dennis Weber classification. Weber classification is based on the level of the fibular fracture. Fibular fracture that is more proximal indicates an increased risk of syndesmotic disruption and ankle instability. There are three types: type A, type B, and type C. Type A, internal rotation and adduction injury, fracture of the fibula below the level of the tibial plafond, usually an avulsion injury from spination of the foot. It may be associated with oblique or vertical medial malleolar fracture. Syndesmotic disruption is rare, but it can occur. This fracture resembles the supination adduction injury in Lag-Hansen classification. Type B Weber classification. It's an oblique or spiral fracture of the fibula near or at the level of the syndesmosis. External rotation injury. It may be an associated injury to the medial structures or the posterior malleolus. It's about 50% syndesmotic injury. Type B, it's probably supination external rotation injury in Lange-Hansen classification. Type C is an abduction injury, fracture of the fibula above the level of the syndesmosis. Syndesmosis disruption always occurs. Associated medial injury in almost all cases. This type C fracture includes the Maisonneuve fracture, pronation abduction, or pronation external rotation. In general, type C Weber ankle fracture simulate an abduction external rotation injury in Lange-Hansen classification. This is the summary of Weber classification of ankle fracture and how it is compared to Lange-Hansen classification. Thank you very much. I hope that was helpful.
Yeah, sure. I think you got something, right? So we continue. So those were able to repeat. Type A is below the anchor joints, will leave the syndesmosis intact. Type B, the level of joint anchor joints, the syndesmosis will be intact and partially torn. But type C, above the anchor joints, and the syndesmosis is always taken away, and most of them, they are lateral. So pelvic ring fracture, this involves the pelvis forms a ring. When the part of the pelvic rings fracture, another part will also fracture, similarly to fracturing of polymins. Pelvic fracture often lead to the significant intra-abdominal bleeding, either due to vesicular injury or from the cancellous bones of the pelvis. This can lead to the shock and death, so need to be emergency resuscitation and trauma management. For pathological fracture, a pathological fracture occurs due to underlying disease of the bone, such as a tumor, osteoporosis, and Paget disease of the bone. They usually occur they may occur with a minor trauma or even spontaneous without any history of the trauma. Common sites are the femur and vertebral bodies. The main cancers that metastatize to the bone are having the mnemonic portable, of which PO is prostate, R is renal, T is thyroid, B is breast, and L is lung. So is portable. Fragility fracture. Fragility fracture occurs due to weakness in the bone, usually due to osteoporosis. They often occur without the appropriate trauma that is typically required to break the bone. For example, a patient may present with a fractured femur after a minor fall. Patient risk for fragility fracture over the next 10 years can be predicted using the FRAX tool. Bone mineral density can be measured using the DEXA scan. The WHO criteria for osteopenia and the osteoporosis are, so you can see the structure here is WHO criteria. You can open up somewhere. We have T-score of the hip bone mineral density. So if it's more than 1, more than -1, that is normal. But if it's more than if it's -1 to -2, that is osteopenia. Less than -2.5, that is osteoporosis. So osteopenia is just -1 to 2.5, and less than -2.5, that is the osteoporosis, and less than -2 plus fracture, that is severe osteoporosis. So the NOGG guideline can be used to guide medical treatment appropriate for individual based on the FRAX score. The first line medical treatment for the reduce the risk of fragility fracture, calcium and vitamins. But again, you can give biphosphates, e.g. alendronic acid. Biphosphates works by interfering with osteoclast and reducing the activities, preventing the reabsorption of the bones. Resorption of the bones. Actually, there are also few key side effects to remember. Reflux and osteophageal erosion can happen if someone is taking oral biphosphate in the empty stomach and sitting upright for 30 minutes before moving and eating prevent this. It's important someone if takes these drugs to sit upright for 30 minutes without moving or just sleeping. A typical fracture, a typical femoral fracture can happen for that reason. Osteonecrosis of the jaw and osteonecrosis of the external auditor canal. Denosumab is a monoclonal antibody that works by blocking the activity of the osteoclast. It is an alternative to biphosphate where they are contraindicated, not tolerated, or not effective. Imaging, X-ray are initial imaging investigation when bone fracture is suspected. Two view that two X-ray taken from the different angle are always required, and a single view may miss the fracture. CT scan gives a more detailed view of bones when the X-ray are inconclusive or further information is needed. Principle of fracture management. The first principle is to achieve a mechanical alignment of the fracture by closed reduction via manipulation of the limb, open reduction via surgery. The second principle is to provide relative stability for some time to allow healing to occur. This can be done by fixing the bone into the correct position while it's healed. There are also various ways for the bone to be fixed in position. We need the external cast, e.g. plaster cast. We need K-wire. We need intramedullary wire. We need intramedullary nail. We need also a screw and a plate or screw. So these are the there are several ways and bone can be fixed. So you need one of these or sometimes multiple. So the external cast, this is a plaster cast, can have a K-wire, intramedullary wires, intramedullary nails, screw, and plates and screw. Management, actually patient presenting to AA will be investigated with X-ray to establish the diagnosis. Patients with fracture require appropriate pain management. A straightforward fracture may be managed in IA, e.g. the Colles fracture in the young adults, and they may require closed reduction if the bone are out of the alignment. A plaster cast may be applied and the patient can be discharged with a follow-up appointment to the fracture clinic. The complex fracture are those that require surgery. A hip fracture are referred to a on-call trauma and the orthopedic team. They are admitted and made nil per month. If they may need operation. They're discussed in the trauma meeting following the day. Typically, this starts at early in the morning, actually. Then seen in the morning ward around, and a plan will be made for further management. This includes discussion with specialists. Complication. The complication will depend on the location of the nature of the fracture. Possible early complication include damage to the local structure, e.g. tendons, muscles, arteries, nerves, and skin, and lung hemorrhage leading to shock and potential death. Compartment syndrome may happen. Fat embolism can happen. Venous thromboembolism can happen. DVT and PE and during immobility. Possible long-term complications include delayed union, slow healing, malunions, misaligned healing, non-union, failure to heal, a vesicular necrosis of death of the bones, infection, which is osteomyelitis, and joint instability and joint stiffness together with contracture tightened by the soft tissue, arthritis, chronic pain, and complex regional pain syndrome. Fat embolism can happen. Fat embolism can occur following the fracture of the long bone, especially the femur, and fat globules are released into the circulation following the fracture, possibly from the bone marrow. And these globules may become lodged in the blood vessels, pulmonary artery, and because blood flow obstructions cause the blood flow obstructions. Fat embolism can cause a systemic inflammatory response resulting in the fat embolism syndrome, typically present around 24 to 72 hours after the fracture. GAD criteria can be for the diagnosis. So what is the GAD criteria? GAD criteria says that you have to look for the respiratory distress. If these are the explanation symptoms of anything happening in the pulmonary embolism or in kind of. So petechial rashes, cerebral involvement. There is a long list for GAD minor criteria, including jaundice, thrombocytopenia, fever, tachycardia. Operating L to fix the fractures reduces the risk that fat embolism can happen or fat syndrome and can lead to multiple organ failure. So management is supportive while the condition improve. Mortality rate around 10%, and that's what will be happening actually. So GAD major criteria is respiratory distress, petechial rashes, cerebral involvement. And minor one, the jaundice, thrombocytopenia, fever, tachycardia, they are also involved. Yeah, so next session then.